Back to meeting değil mi? Back to meeting mi diyeyim? Back to meeting mi diyorum? Hello, everyone. I hope you can hear me. Okay, I'd like to welcome all of you from Istanbul. It's a great honor to give this lecture for Iraqi Society of Gastroenterology and Hepatology. And before going through my lecture, I'd like to send my special thanks to Pentax Iraq, Pentax Europe, and Pentax Turkey. Also a special thanks for my institution, Live Hospital Ulus, for providing this platform. This is a part of IJMA's International Contemporary Medical Academy lectures. So this lecture will be listed under those activities. So today I will be talking about the basics of EUS, EUS stations, scopes, and just practical knowledge I will try to give you. So let's try with the first slide. Okay, this was taken about 3 years ago when the first Iraqi group has visited my hospital, Marmara University, and we were hoping to meet again and have iftar together, but unfortunately we failed. But the best part was I met many of you, some of you. I know you are more than, your number is much more than I met. But one of you was Dr. Nawal. I think she is with us right now. And she became like a second sister to me. And I appreciate her for organizing this lecture as a bridge between Turkey and Iraq. Okay, and I pray for the next round table meetings in the near future will be available. So I hope we get rid of the COVID. Okay. By the way, this lecture is being broadcasted on YouTube online, but you don't have to take notes. So you can watch the videos after the lecture over and over again. Okay, as many of you already know, I have an endoscopy atlas published in Turkish, and it's actually a translation from English. Also, some chapters are added. So it's a book and an atlas, and I believe it's a good tool for learning for endosonography. And I will be using some of the illustrations from this book in my presentation. Okay, as you know, there are two main scopes of linear and radial scopes available. Of course, Pentax is not the only producer. There are other companies producing EUS scopes, but those are the latest models released by the company. Just to make it more demonstrative, I produced those pictures for you. And this is the old model of EUS probe, which is the one I'm currently using. And this is the latest one. Of course, I had the experience to use them, but I don't have the chance to use it yet. So this is the one I'm using. I think you understand how the tip has evolved, how the tip length has changed over time by Pentax company. So it's like driving a Chevrolet 1965 with the old one, sorry. And the new one is much more compact and smaller, which is like the Mini Cooper. But of course, the old one has a character. And it's a good scope, and I'm happy to use it. Still, I can use it. To compare the length and the thickness of the thickness and the therapeutic channel width of those scopes, I made this table for you. The common linear EUS scope we are using is the therapeutic one, and the latest model has got a 4 millimeters of therapeutic channel, which is quite good. You can use any of the therapeutic interventions using this large channel, but the thickness is still a bit high. It's still a thick scope. When you compare with standard gastroscope and duodenoscope, it's quite thicker. The thickness is 14.3 millimeter. There's another type which has a smaller diameter, but it's more for pediatric patients or for maybe diagnostic procedures. Radial scope has got a smaller diameter, but it is still thicker than the standard gastroscope. Of course, we have mini probes. If you are interested in seeing the superficial mucosa in detail, then you should use mini probes. With mini probes, the mucosa can be seen in 9 different layers. Okay, I don't want to scare you with the complications of EUS, but before starting, I would like to remind you, risk of perforation is an important issue with diagnostic EUS. So for the beginners, they should be aware of this risk. The most common area of perforation is seen in the duodenal bulb, in the junction area between the duodenal bulb and the second portion of duodenum. But the second most common area is the cricopharyngeal area during intubation. So you need to be really careful while intubating your patient. This is a video that I produced for you, but every endosonographers may express different style while intubating. So who is correct and who is not incorrect is not the issue. You can develop your own style, but I can express you my way of intubation. I prefer to keep the head of the patient a little bit flexed, not extended, just a little bit of like 20 or 30 degrees of flexion. And then, as you will see in the video here, sorry, muted. Okay, I keep the tip of the scope like this, flexed. So down, using the big wheel of the scope, down, make the tip of the scope angulated downward. So this way, you should enter through the mouth, and you should feel when the tip of the scope touches the pharynx. So this is just a matter of feeling. You have to develop your feeling, your sensation of touching the pharynx. After you reach pharynx, then you should open the angulated tip and straighten your scope. No matter what the other people tell you, this is the intubation using a linear scope is a blind procedure. So you have to be gentle, you have to be careful while intubating your patient. Okay, let's continue our video like this. Oops. By the way, because of after the COVID, as you can see, me and all my co-workers wear an N95 mask on top of a standard surgical mask, and I have invented another way of prevention for the COVID infection. I make a small tear in the mask of the patient, and then through this aperture, I introduce my scope. Yes, just like this, using the big wheel, I angulate it, and after I touch to the pharynx, I feel that I'm at the pharynx, I open it and straighten the tip of the EUS. And finally, I see, by the time I see esophagus, I'm already at least 18 centimeters down from the incisors. So this is the way you intubate it. Of course, you can develop other techniques for intubation, but this is my way, and I'm practicing this intubation style for the last 16 years. Okay, EUS examination means you have to go stations by one by. Again, here, everyone may have their own style, own way. Some people may prefer to go all the way down to D3 first, or deep D2, the second part of duodenum, and then they may come upward. But me, personally, I prefer to start with subcarina and then go downward. Okay, so let's do it. Let's start with subcarina. Subcarina is the 30 centimeter from the incisors. When you go to this distance, you will readily see left atrium. It's the biggest structure you will face in this area. It's much bigger than the left ventricle. So after you see left atrium, try to localize pulmonary artery. Actually, it's left pulmonary artery, and the area, the triangular in between those two vascular structures is called subcarina. It is the area underneath the bifurcation of trachea. Okay, it's important. It's an important area because most of the cancers located subdiaphragmatically, and the ones located in the above the diaphragm are easily can easily metastasize to this area. I have received an email from one of you asking for the mediastinal lymph node stations. Well, of course, it's it's the subject of another lecture, but subcarina is the 7th mediastinal lymph node, as you can see in this illustration, and the other lymph nodes you can easily localize are station 4L, station 8, and station 9. Station 8 and 9 are paraesophageal lymph nodes that you can find easily. Okay, I will explain how to find station 4L also. Okay, it's also possible to find station 5. Station 7 is the subcarina. Okay, so this is another video. As I have mentioned before, you can easily localize, you can easily find the left atrium. And once you find it, it's my habit to go through heart chambers real quickly. Of course, we're not doing TE, transesophageal echocardiography, but you can find or maybe some small cardiographic findings by checking those structures. Between left atrium and left ventricle, located the tricuspid mitral valve, as you can see, and from left ventricle, you can see the exit of aorta, and bicuspid aortic valve can be seen as it's readily seen here. Okay, so left ventricle, the arising part of the aorta, and then it will go upward and make the arc of aorta. So let's skip to the next video. All right. Okay. After you find aorta arising from left ventricle, you can trace it all the way up by pulling your scope upward and rotating it counterclockwise position. You will come to an area above the subcarina where the two main vessels are seen. The one on the right-hand side is aorta, and the next one is pulmonary artery. And this triangular area in between those two major vessels are called aorta pulmonary window. And this area is actually mediastinal lymph node number 4L. And the deep part of this area is station 5. All right, after mediastinal examination, we go down to GE junction or cardia region, which is 40 centimeters from the incisors. This area is again an important area because it's possible to examine almost all kinds of structures from this area. So if you cannot pass through the pylorus, don't worry, you can see many of the structures that you were aiming to see just from this area. Here you have to stick with your guiding structures. They are important. If somehow you get lost, please don't be lazy. Go all the way back to your guiding structures, localize them, find them, and try to go or try to proceed after finding the structures. The main guiding structures are liver, aorta, celiac takeoff, splenic artery, and main pancreatic duct. Of course, there are other structures, but those are main important structures. From a practical point of view, I prefer to find liver first. Some other people may find aorta first, or they may trace the aorta all the way from mediastinum down to abdominal area. But this is my style, and I find it very easy and practical, and that's why I want to share my style with you. So try to, at 40 centimeter, try to locate liver in this situation, like a crescent. And after localizing, after finding this picture, start to do clockwise rotation. The next structure, while you are torquing your scope, will be abdominal aorta. Again, it's easy to find because it will lie on the spines, and spines are easily seen. Even the interspinal arteries can be seen easily. But my advice is try to locate abdominal aorta in a horizontal way, just like the one in the picture. After localizing aorta, you will keep torquing gently and slowly, keep torquing your scope, and you will see the first structure as celiac takeoff or celiac trunk, and the next one will be superior mesenteric artery. And sometimes you may also see the third branch of left renal artery. In this Doppler view, celiac trunk and superior mesenteric artery is readily seen. If you go down again, you can see the left renal artery. Okay, this video will summarize what I have just told you, what I have just explained to you. So this is the liver in the crescent shape. Let's watch the video. Okay, so after liver, you can see the abdominal aorta. And from abdominal aorta, celiac takeoff, superior mesenteric artery. And the celiac artery, if you trace the celiac artery, it will give three branches. The one going towards the right-hand side of your screen will be left gastric artery. It goes to right, but it is the left gastric artery. And the one going top is splenic artery, which will the artery we will be tracing. And the third one is the common hepatic artery. By the way, I have realized that I forgot to to explain an important part related to this ball that you can see on the screen. European countries, especially Germany, prefers to use the ball on the left-hand side, not here on the left-hand side. Where is my cursor? I have just lost my cursor. Yes, that's it. So, but usually American style, and we, all the people here in Turkey, we use the ball on the right-hand side. That means the endosonographer is standing at the foot of the patient and facing towards the head of the patient. So it's caudocranial orientation. If the ball is on the left side, then that means the doctor, the endosonographer, is standing on the head, at the head of the patient and facing towards the feet of the patient. So what's the difference in between those two positions? When we use the ball on at this side, on the right-hand side, that means the organs located on the right side of the body will be appeared on the left-hand side of the screen. In other words, liver will be located on the left-hand side. Okay, so here celiac takeoff, and when we trace it, it will go up here. We just missed it. Yes, splenic artery and splenic vein. Splenic artery is closer to our scope, and splenic vein is away. But when you see those structures together, that means you are at the corpus of pancreas. All right. So another video. Some of my videos are courtesy of Dr. Hussein Okasha from Egypt, and I thank him for sharing his videos with me. So this is a celiac takeoff, superior mesenteric artery. Yes. This is a very nice illustration of left gastric artery, splenic artery, and this one is the common hepatic artery. So we have seen just the branches of superior of the celiac takeoff. Once again, okay, common hepatic artery, and this is the portal confluence. Yes, okay, let me explain it here. Okay, so the portal in this area at the cardia, the splenic vein will go towards the upper part of the screen, and portal vein will go down towards the hepatic hilum. Okay, hepatic hilum is somewhere here, although we do not see it in this portion, but it's here. So portal vein goes down, and this part is the superior mesenteric vein. So SMV, superior mesenteric vein, splenic vein, and portal vein. So this is the confluence, and the area in front of the pancreatic area, in front of this confluence, is the neck of the pancreas. Okay, so just to summarize once again, the portal confluence its branches. Okay, superior mesenteric vein, splenic vein, portal vein, the neck of the pancreas, and this is the pancreatic vein, main pancreatic duct. Okay, so let's skip to the next video. All right. Okay, so when we are at the corpus of the pancreas, or in another word, when we see both of the splenic vein and splenic artery together, this is the corpus of the pancreas, then we can move to the tail of the pancreas. How to do it? Just pull your scope a little bit out, a few centimeters out, while counterclockwising, torquing your scope. You will get to the, first you will see the left renal, left kidney, and then left suprarenal gland, as you can see in this picture. And when you torque all the way down, you will end up at spleen. The area in front of the spleen is the tail of the pancreas. Okay, so another video. So this is the corpus, and we go all the way. That's the kidney and spleen. So once again, from corpus, slightly pull your scope. Another way to get to spleen is to trace splenic vein. If you follow splenic vein, it will go to splenic hilum, and you can reach to the tail of the pancreas. So corpus, we pull and rotate it. We have seen in a small portion, maybe some of them, some of you have realized also the suprarenal gland, the kidney, and spleen. All right. Again, the seagull-shaped suprarenal, left suprarenal gland, and we end up at spleen. So this area is the tail of the pancreas. Oops. All right, so although this does not look like a normal pancreas, this is the corpus area of the pancreas. Splenic artery and splenic vein, both seen together. Pancreatic duct, main pancreatic duct, or Wirsung, is another important structure we should examine carefully. But the shape, regarding the shape of the organ, in the corpus region, it follows quite a horizontal line, horizontal way, just like this. So it will follow a straight line at the corpus of the organ. But when you move towards the tail, it will sharply make a turn, and it's called tail fail of main pancreatic duct at the tail of the pancreas. So in this picture, you can see the tail fall. So abruptly, all of a sudden, the pancreatic duct may fall. So this is the normal trace, normal anatomy of the duct. And a second fold will be seen towards the head of the pancreas, and it's called head fold pancreas. At this area, or in this diagram towards the outside of the organ, you may see duct of Santorini. So you may realize if there is a pancreatic divisum is present or not. This is the head fold of the pancreatic duct. So pancreatic duct goes horizontally in the corpus of the pancreas till the tail. When we reach the tail, it will sharply or suddenly make a fold at this area. Or if you go towards the head side, towards the head of the pancreas, you will notice another fold in the pancreatic duct. In this picture, Santorini is not apparent, but sometimes when the divisum is present, you can see Santorini. I have lost, yes, here going towards outside or the opposite side of the pancreatic duct. So normal pancreatic duct or Wirsung will go towards the duodenum, so it will go downward, but Santorini will go upward towards the opposite side. Okay, let's skip that one. I will talk about pathologies tomorrow. So after cardiac examination, if you push your scope a bit downward, you will see hepatic hilum. It's also an important area, especially for stone disease. But here at this area, the structures be seen just as the opposite way you see at the bulb of the at the bulb area. So this is a short video, but it illustrates very well. So this is the hilum, and the upper part here is the portal vein. And CBD, well, at this level, of course, it's not CBD, it's common hepatic duct. So it's located outside, located in the distant part of the scope. So the closest one is portal vein and hepatic artery, and the distant one is common hepatic duct. Okay, so here it's very nicely seen at this area. Doppler will be helpful at this position. So this is the hepatic hilum. Okay. Oops. Okay, another important structure we should check is the uncinate process at the level of cardia. You do not have to go all the way down to examine uncinate completely. You can check it from stomach. All you need to do is to follow the superior mesenteric artery. So this is the abdominal aorta. You can see the celiac takeoff and the superior mesenteric artery as a second branch going outwards from aorta. So if you trace superior mesenteric artery, SMA, together with aorta, the area in between those two vessels, the branch of aorta and the main aorta, is uncinate process. So let's watch it. Okay, clearly superior mesenteric artery and aorta, and the area, the pancreatic area in between those vessels is the uncinate process. You can also see the pancreatic duct. Okay. So this area is the uncinate process. Before getting out of the stomach, make sure to examine gallbladder. The best area you can see gallbladder is the pre-pyloric area. Sometimes you can see gallbladder at the post-pyloric area as well, but when you descend towards the antrum, just at the pre-pylorus level, you will see gallbladder for its whole entirety. Okay, now we could approach to duodenal bulb. My favorite guiding structure here is the portal vein. You may take other structures like aorta or inferior vena cava, but my style is portal vein. It's you can find it easily again, and once you find the portal vein, CBD will be sitting in front of portal vein. So your probe, portal vein, and in between lies CBD, common bile duct. And this area is the head of the pancreas. Okay. All right. So, portal vein, common bile duct, and main pancreatic duct or Wirsung. And this area, the whole area, is head of the pancreas. Another video. Here at this level, the tubular structure here is superior mesenteric artery. Actually, this part is the distal part of the superior mesenteric artery. As you remember, we have seen the origin of the SMA from the upper portion of the cardia, and here is the distal part or mid part of the superior mesenteric artery. Okay, so superior mesenteric artery. If you rotate clockwise from superior mesenteric artery, you will see the confluence, portal confluence. Okay, so now our position has changed, and the tributaries of the portal vein has changed their orientation. This is the portal vein, and it will go towards the portal hilum, and this is the superior mesenteric vein, and the one going deep towards the deep structures is the splenic vein. Okay, so once again, splenic vein, superior mesenteric vein, and portal vein. The area, the area here is the head of the pancreas. Actually, superior mesenteric vein is the border. It draws a border for the head of the pancreas. Let's continue. Portal vein, do clockwise rotation from superior mesenteric artery. You will reach to portal vein, and in front of portal vein is the CBD and main pancreatic duct, common bile duct, and pancreatic duct. So if you do the opposite, you will find the common bile, the portal vein. Okay. If you do keep doing clockwise rotation, then you will reach to major vessels, aorta and inferior vena cava, which just appeared in our, yes, that's it. So let me explain once again. Okay. So inferior vena cava and aorta. The largest structure is inferior vena cava and aorta. So if we need to summarize once again, this thin lining, thin structure is superior mesenteric artery compared to aorta, of course, superior mesenteric artery. If you keep doing clockwise rotation, you will reach to the portal confluence, and in front of the portal confluence is the CBD, and somewhere here is the pancreatic duct. And keep doing clockwise rotation. Let me see if I can find. Okay, we get to superior mesenteric artery again. And yes, now inferior vena cava and aorta lying side by side. So this is the structures we can see from the bulb, from duodenal bulb. All right. Just to summarize how to manipulate yourself to find the structures at ampulla, I have summarized some small tricks in this slide. So to reach the ampulla, I advise you to move down towards D2, the second part of duodenum. So pass over the papilla. You don't need to see it completely. Just advance your scope towards the deep duodenum and then shorten your scope. So what does it mean to shorten the scope? All you need to do is to tip up by moving the big wheel of the scope, tip up your scope and torque your body a little bit towards the right, and then pull back your scope. So this way you will shorten your scope and you will be able to locate aorta. The aorta, the area in between aorta and SMA is the uncinate process of the pancreas. Then after seeing the uncinate process, keep pulling back gently to locate papilla. When you see the two ducts, pancreatic duct and common bile duct approaching together, this area is papilla. So this is an easy way to find the papilla. Okay. So shorten your scope, try to see the aorta, and when torque your scope, you will see the superior mesenteric artery and the uncinate process in between those two vessels, and then keep pulling back your scope, then you will see the two ducts coming together, forming the papilla, as you can see in this slide. So there are many stack signs in EUS. This is another stack sign. So in this picture, the pancreatic duct and common bile duct meet at the level of papilla, and CMV draws the border of the head of the pancreas. So this side is the head of the pancreas, and this side will be the uncinate process. I'd like to take your attention for the CBD CBD position, because at this position CBD will be just the opposite of the way you see at the stomach, and here at the level of papilla, CBD will move towards the right of the screen. It will move out towards the right, and pancreatic duct will move towards the deep part of the screen. So pancreatic duct comes from down up to papilla, and CBD coming from the far left of the screen towards papilla, and they meet at the level of papilla. In the bulb area, remember, in the bulb of the duodenum, CBD was lying horizontally, quite horizontally, and pulmonary and pancreatic duct was in the deeper area. So papillary region is different than the bulb area. Okay, this is the uncinate process that I have just explained to you. So aorta, abdominal aorta, and superior mesenteric artery, you will be able to see mesenteric veins, mesenteric vessels on this side, aorta, inferior vena cava. So the area between aorta and superior mesenteric artery is the uncinate process. But here, I will play the movie once again. Yes, you may notice an hypoechoic area in the uncinate process with the pancreatic duct. So this is because of the intrauterine life. As you may remember, the ventral budding of the pancreas and the dorsal budding of the pancreas from the intestine, ventral budding and dorsal budding. And when the intestine completes its rotation, they will fuse and form the pancreas. But during this fusion, the ventral part of the pancreas may stay more hypoechoic. And this is called the ventral anlage, or ventral hypoechoic pancreas. This is important because sometimes endosonographers may think that this is a malignant lesion, hypoechoic and malignant lesion, and they may try to obtain FNAs from this area. But this is completely normal pancreas, it's ventral pancreas, so there is no need, you should not touch it. Okay, this was an important trick for the beginners. All right. So this is another stone. Okay, we are approaching to the end of our first hour. Today, I have explained you linear EUS. Tomorrow, I will be talking about radial EUS briefly, and go over some pathologies, some common pathologies you can see with EUS. So if you have any questions, you can raise your hand. Let me see, or we can, or any question I can have it. Let me have. Okay, chats. All right, let me see. Okay, I hope all are there. Yes, they are all here, Dr. Nawal. Okay. All right, you can ask your question. Thank you. That's information. You're welcome. Thank you. Okay, I don't see any questions actually. I have, let me see you. Yes. Thank you. Okay. As I have mentioned before, this lecture will be available on the YouTube channel of Live Hospital International, so you can go there and watch it if you like again. And for tomorrow's lecture, you have to register again, and you will receive another invitation from Mr. Hassan. And I thank to Mr. Hassan Erdal. He was with us throughout the whole lecture. And I think he did a good job. Thank you, Dr. Nawal. I hope I will see you face to face in the nearest future, in good health, of course. Okay, my advice for all of you is go ahead and start doing EUS. EUS is a kind of procedure you will learn as you do it, as you practice it. Well, of course, those teaching tools are important. They will help you to learn, but the most important part is to start it. No matter how you do it, just start it. Intubate your patient carefully and try to translate the structures you see. Okay, if there is no question, I will close this panel and hope to meet you tomorrow evening at 9 o'clock again. If you have special preferences like Stone's disease or any kind of disease, you can send an email to Mr. Hassan Erdal and he will pass me. Okay, all right. I send you all my regards from Istanbul. Bye-bye.